In a world of healthcare, where compassion is paramount, there exists a place that goes beyond the ordinary. It's not just about responding swiftly in times of crisis, it's about being a beacon of hope during life's most challenging moments. It's not just about treating an illness, it's about engaging your child's imagination and turning their visit into a memorable adventure. It's not just about a diagnosis. We make it our mission to ensure that you fully understand your condition while going out of our way to simplify medical jargon. It's not just about serving meals, it's about nourishing your body and soul with delicious and nutritious food tailored to your dietary needs. It's not just about maintaining cleanliness, it's about a pristine and hygienic space that promotes healing and well-being. It's not just about performing a surgical procedure, it's about meticulous planning and executing each step with precision and expertise. Our team of doctors, nurses, and support staff work in harmony, driven by the belief that exceptional healthcare is a combination of expertise and heartfelt compassion. Welcome to Clinics, where health and care meet.
Good evening. Thank you, colleagues, and indeed, welcome to Clinics, where health and care meet. It's a pleasure to welcome you once more to this webinars that we are hosting on a weekly basis. And we've been doing this for the last 2 years or so, since the beginning of the lockdown and when the pandemic was declared in 2020, and we've been going on. And it's because of your support that you are able to do so. And we just want to thank you for supporting Clinics Health Group in our endeavor to continue to bring you continued medical education so that you can get your CPD points also to remain abreast of medical advances and technologies, and also to improve clinical care, quality of care wherever we are as healthcare professionals, whether as medical doctors, nurses, allied healthcare professionals, or pharmacists, or other interested parties or managers in the healthcare industry. These webinars are CPD accredited, and so we request that when you join in and log in, you do give us your contact details, your name, your surname, your practice number, your registration number, so that we send this information to the Health Professions Council, the Nursing Council, that whatever registration body that you are registered with. We've noticed that some colleagues have complained that not many, that they were not able to get their CPD points uploaded. If you are one of them, please do indicate and send us your a query to webinars@clinics.co.za, or you send it to myself, rbila at clinics.co.za, and we will attend to it. The team of colleagues will help you to get your points sent to you. And know that these webinars are streamed live on YouTube. I've had comments from colleagues who are able to log into YouTube. It's good for you, so that at least when you want to watch the video, the presentations, or get something that you missed, you're at liberty to do so at your leisure. And so this evening we are doing the same thing. We are already live on YouTube. So we're excited to bring you a regular on our webinars, Professor Zach Koto, and he has been so generous to us that he is currently streaming in from Mombasa in Kenya. And he is availed his time that even if he's out of the country, he's still able to do so. I think that is the advantage, the pleasures of technology, that we are able to get the lectures even sent in from far out of the country. And thanks a lot, Prof. Koto, for making time to be with us. The different time zones, you're 1 hour ahead of us this evening. And so this evening, he is going to be talking to us about metabolic bariatric surgery? Is it relevant? He's well known to us that he's a pioneer in laparoscopic procedures in the management of trauma in South Africa, and he graduated with an MSHB from the then Medusa, also from University of Health Sciences, where he's the head of department. And he also has a doctorate in surgery from the University of KwaZulu-Natal, also holds a fellowship from the College of Surgeons South Africa, and also a member of the Fellowship of American College of Surgeons. And is renowned for performing the first laparoscopic autobiafemoral bypass graft in South Africa in 2012. His doctoral studies showed no missed injury in penetrating abdominal trauma during laparoscopic surgery. And could go on and on about Professor Koto's qualifications, but he's well known to all of us. So it's a pleasure to welcome you, Prof, that you can talk to us about this important topic about metabolic bariatric surgery. Thank you very much for once more availing your time and being with us at this clinic's webinars. Thank you.
Yeah, thank you very much, Dr. Ray Bila. I don't know if I'm audible from that side. I'm not able to start my video. Maybe if the host can.
You're audible, and Kamu can just let you enable your video.
Hi, Prof, it's enabled.
Okay, I'm just trying to. It says unable to start video. Let me just try once again. It says you can't start your video because the host has stopped it. So I don't know if you maybe can just maybe look at that again. Are you able to? Yeah, from my side, no, my screen says you can't start your video because the host has stopped it, the video.
Okay, I'm not sure what's the problem. No, it's fine, Prof. You can continue to
maybe give him the host rights,
share your slides, and then you can continue to share your slides, and then we'll sort that out.
All right, thank you very much. Let me just share my screen. All right, is my screen visible? Okay.
Yeah, sure, it is.
Yeah, all right. No, thank you very much. Once again, thank you very much, Dr. Raymond Bila. I would like to thank the Clinics Health Group for this opportunity to engage and discuss with colleagues a subject that is very close to my heart. And I don't take very lightly this privilege, the privilege of the podium, to interact with my colleagues, on this very important topic, which is really metabolic bariatric surgery. And as Dr. Bila has said, the title today really is to begin to unpack this topic and this real problem, which is bariatric surgery. Is it really relevant today? So I'm hoping that in my talk today to cover a few areas, basically a few remarks as a way of introduction, and then secondly, to look at the magnitude of the problem of obesity, not only in South Africa, but internationally. And then basically to also scan, the horizon around evaluation of obesity, including how do we stage the disease of obesity and the role of BMI in deciding the management plan of these patients. So I will be able to discuss that in the limitations of BMI and the surgical approach with utilizing BMI indications for surgery, the different types of surgery for bariatric patients, as well as the complications, and then I'll conclude. Now, in 2013, the American Medical Association designated obesity as a chronic disease. I think it's very important, to note this. Again, like all other chronic diseases, the prospect of complete cure is very remote. It's just like diabetes, like hypertension. It's like, thyroid, hypothyroidism. These are chronic disease. We can control it and control it significantly, but we cannot cure it completely. And the American Heart Association, as well as the Obesity Society, then published guidelines basically to craft a management plan of this condition. And these clinical guidelines were published really with a view to assisting clinicians who are involved with this disease, to managing these patients, who are very, very difficult and challenging, as it were. Now, the body mass index, and weight-related complications, they were published. These were published, and weight-related complications, rather than weight loss target, really was the main thing, as opposed to treatment, which really looks at a very simplistic way of losing weight, as opposed to really addressing really the major complication of this patient. How big is the problem? And this is what really faces us. It is indeed a global threat. It's worse than COVID, it's worse than other pandemics we've ever seen, and is continuing to rise. This is what we face. Now, if you look at this, this is a global map. If you look at the red there, this is where the obesity is well over 40%. You can see there in Africa, South Africa, in the continent of Africa, is really a major problem there. You can see Zimbabwe, you can see Botswana, you can see Namibia, but look at other countries as well. So it is indeed truly a global problem. This is what we face. It's really a tsunami. If not taken care of, and if not addressed, as in a significant way, it really threatens all of us on planet Earth. Now, the rising prevalence of obesity and overweight and obesity in a number of countries, and as we said, as we have indicated, has been described as a pandemic. Now, around 2010, overweight and obesity already were estimated, to cause, run about 3.4 million deaths, according to several publications, 3.9% years of life lost, 3.8% of disability-adjusted life globally. If you look at some of the publications in the USA, they've suggested that unabated, the rise in obesity could well lead to future declines in life expectancy. Indeed, it could reverse the significant gains that humankind have made over centuries. Now, the WHO adopted a voluntary target of halting the rise of obesity by 2025. We're already in 2023. It doesn't look like this strategy is working. This is a recently published study looking at the prevalence of obesity in 147 countries. And here, if you look at red, this is about the prevalence of 46.8%. And this is where we are, in South Africa, Australia, the US, and part of the Southern America. This is again a published study looking at the over time, starting from 1981 to 2008. The prevalence again, then the rise of obesity. Now, the solid line represents males, and the another shaded line represents female. This is East, Mediterranean. If you look at there, you can see clearly once again, there's a beginning rise. There's a steady rise of obesity, both in men and females, from 1981 to 2008. If you look at Europe, for example, once again, a similar pattern of a rising incidence of obesity, both in males and females. And this is the same as in Africa and other countries as well. Now, this is another paper that was published again, looking at global females, which is a solid red line, and developing females, with the little trials. But what this little diagram shows again is a steady rise of obesity, especially in females, starting from 1980, 2012, and settling up to the current day. This is a publication in the Journal of American College of Surgery, American Medical Association in 2010, looking at the body mass index. And again, here, if you look at this again over the time period, there has been certainly an increase in the body mass index on average in men, as well as in women. And we look at the prevalence of obesity, is said to be around 32% among male in certain countries, 35% in female. Once again, this indicates a rising significant problem. When you look at the socioeconomic impact of obesity, again here, the solid bar chart represents males, and the darker one, the lighter gray one, females, and the shaded one, both sexes. But again, what it shows, again, when you look at high income countries, not significant difference, but upper middle income countries, there's clearly significant difference. Again, females leading the charge in terms of the prevalence of obesity in upper middle income countries. Now, screening and diagnosis, these are the older guidelines, older guidelines. Basically saying patients who, in terms of classification, would say 18.5 BMI of between 18.5 to 20.9. That's a normal weight. And then once you go above 25 to 29.9, you are said to be overweight. And then 30 to 34.9 is said to be class 1 obesity. And those that are 35 to 39.9, class 2 obesity. Once your BMI goes above 40, you're said to be class 3 obesity. So we've moved away from the old classification of the super obese individual, but now we're talking about class 1 up to class 3 obesity. Now, when you look at these guidelines, as articulated by the American Medical Association and other very notable organizations, there has been a lot that changed since the development of these guidelines. We know that the FDA approved 4 new medications for the long-term treatment of obesity. And even though these lines remain the cornerstone for treatment of obesity, I think one must recognize that a lot has changed. And since the publication, several organizations in the field of obesity have advanced our understanding of obesity. Now, how do we evaluate these patients? The BMI, I'll talk a little bit about BMI and the limitations of BMI. Now, the waist circumference should also be considered, particularly those patients where the BMI is around 25, 35, because the waist circumference is really a proxy of visceral fat. It's a proxy of actually body fat composition. For example, waist circumference of at least 102, which is about 40 inches in men, and at least 88 centimeters, which is about 35 inches in women, indicate abdominal obesity. And this is the type of obesity that is directly linked with major obesity-related complications such as cardiac disease. Now, a lower threshold certainly should be considered for, especially for those patients that are outside the United States. We should have a waist circumference of around 94 centimeters in men, and that one about above 80 centimeters in female. So this should be looked at. Once again, this is indicative of abdominal obesity, which has got a major problem, as far as body composition is concerned. This was a paper published by Forbes et al. 1987, basically looking at the relationship between lean body mass and fat mass in kilogram. And it basically shows a non-linear relationship between proportional body weight loss or gain as a lean mass and total fat mass, according to these authors. So again, there's no linear correlation between lean mass and fat mass. But here's comes the problem of BMI. This is our total body composition, which basically looks at, for example, individuals that are obese have a high BMI, including those that are sarcopenic obesity will have a high BMI. And so does an individual such as bodybuilders, for example, rugby players, those individuals with a high BMI. So if you look at a prop or a hooker who plays for the Springbok, will have a BMI of 40. Should that patient get a metabolic surgery? The answer is no, clearly, because they've got lean body mass. So it's a problem. So it lumps together patients that have, BMI with lean mass and BMI with excess fat. So all the same, they have the same BMI. So clearly, it becomes very important to be able to individualize these patients and be able to assess them as individuals. Once again, the waist circumferences certainly assist us. But even having said that, the BMI is a relatively simple tool to assessing these patients, but it's got certainly serious limitations. How do we assess these patients, who are overweight? They certainly should be screened for pre-diabetes or diabetes. They should be screened for hypertension. We should look at metabolic syndrome in these patients, certainly cardiovascular disease. And of course, they've got non-alcoholic fatty liver disease. And this is one of the problems that certainly hepatobiliary surgeons are now seeing on an increasing basis. Patients who come with cirrhosis because of non-alcohol fatty liver disease. Patients require liver transplantation because of it. Again, because of this major tsunami that is facing us, non-alcohol fatty liver disease really becoming a significant problem. And these patients may have, osteoarthritis, and it's important that they be assessed for that. And of course, they have other psychosocial problems that also should be looked at. They should be evaluated for obstructive sleep apnea. Some of them, have difficulties in falling asleep. They may have asthma. They often have a reactive airway. They've got gastroesophageal reflux disease. And all of these things require a very meticulous and thorough evaluations. So clearly, these patients require a multidisciplinary team approach and a very meticulous assessment. This is the Edmond Obesity Staging System. Basically, it looks at a number of things. It looks at the medical conditions that these patients may have. It looks at the mental function of these patients, what their functional status is. And based on that, this patient can then be staged from 0 all the way to stage 4. For example, stage 3 patient, these are patients with end organ damage, who have a severe mental disease, who have a very severe, functional limitations. So it's a fairly objective way of assessing these patients in terms of their medical, mental, and functional status. Now, when we screen them, these patients, especially females with overweight, they certainly should be screened for urinary incontinence, which can really be a social embarrassment. They often have problems. They are not, accepted, by society. They may have urinary incontinence and other problems. And certainly those that are premenopausal should be screened for reproductive abnormalities. Sometimes they have polycystic ovarian syndrome and other problems, certainly infertility and so forth. And certainly they should be advised, for other things, other risks, including infertility. With men, they may have hypogonadism, which certainly may be a major problem in their families. Now, assessing risk for overweight, we should measure their weight, we assess their lifestyle, take a thorough and accurate medical history. But again, this is done on an MDT basis where there's multiple colleagues that are involved, in evaluating this individual. They're discussed in a multidisciplinary team, and a decision is then decided upon, and a management pathway is established for this patient going forward. What is our approach to metabolic surgery now? In terms of operations, the indications, again, the old indications, is unsuccessful history of lifestyle modification. If the patients have got a BMI of more than 35 or a BMI of 30 with obesity-related comorbidities, certainly those patients should be considered for surgery. That being said, I think it's important to remember that, even those with low BMI, so BMI, as I said, it's not cast in stone. There are certainly other considerations, particularly patient ethnic differences, patients with Asian ancestry, even lower BMI, those patients are particularly prone to developing obesity-related complications. For example, if a patient has a lower BMI and we are struggling to control their diabetes, it is not unreasonable to consider that patient certainly for metabolic surgery. The contraindications are listed here on the slide. Clearly, if someone is on controlled psychiatric illness, that patient certainly cannot be considered for bariatric surgery until their psychiatric illness is under control. But we operate quite a number of these patients, they have major depression, but they are well controlled. Any psychiatric illness that is well controlled, so it's certainly not a contraindication to operate in this patient. And of course, the high anesthetic risks is a relative contraindication. Patient with short-term life-threatening disease, if a patient has got, a very aggressive, type of malignancy, certainly something that we should consider not to operate this patient. Of course, alcohol and substance abuse, if it's not, sorted out, certainly this patient will not be wise to operate this patient. So once you've decided to operate them, they need, as I said, multidisciplinary approach. They need counseling. They need a very meticulous and thorough assessment. They need a workup. And of course, we discussed the procedure selection, as I will discuss, in subsequent slides. This is the recent published guidelines from the ASMBS as well as the IFSO. ASMBS is the American Society of Metabolic and Bariatric Surgery. IFSO, International Federation of Surgery Against Obesity. They revised their guidelines in 2022. Now, if you look at the major difference between the old guidelines and the current guidelines, they basically revised down the indications for bariatric surgery. It used to be 35 with comorbidities or 40 without comorbidities. They've lowered that down. So anybody with 35, BMI of 35, above 35 should be considered for bariatric surgery. And anybody with a BMI of 30 to 34 with obesity-related comorbidities certainly should be considered for bariatric surgery. But I think they make a very important point around, patients, of Asian descent certainly would operate them at a lower BMI. Now, this is the often quoted study by this group of investigators, from Sweden. What is particularly, what particularly stands out about this study is the fact that it's got a very long-term follow-up, 20 years. And then these are the procedures. Now, if you look at, for example, these are the control at the top, and then here with an orange is the gastric bending, vertical bended gastroplasty, and the gastric bypass procedure. What is clear, in this study, very important study, is the fact that these patients over a prolonged period of time had sustained weight loss. Now, again, if you compare it to other, interventions, be it dietary intervention and other interventions, certainly there's no intervention other than surgery that gives you sustained weight loss. And I think it's important to notice this. Even these other procedures, for example, if you look at some of the procedures that certainly maintain weight loss over a prolonged period of time, some of them have certainly now no longer been utilized. They are regarded as procedures that are no longer suitable or have serious problems. But even those ones, they're able to offer these patients sustained weight loss over a prolonged period of time. And this cannot be said with medical therapy. There are now newer drugs, GLP agonists, that are set to offer patients, excess weight loss, which is comparable to surgery. But one thing I think over a period of time, surgery comes off tops. In terms of control of comorbidities, surgery still comes off tops. I think we'll discuss that maybe a little bit later. Now, these are the surgical options for obesity surgery. We have three types of procedures. We have those that are restrictive. Basically, it allows the patient to eat less. And a typical example would be a sleeve gastrectomy. Sleeve gastrectomy, this is where we remove 2/3 of the stomach and the patient eats less. Although the mechanism is restriction, it's not pure restriction. I think we'll discuss that a little bit later. And then there are these malabsorptive procedures, ileal bypass, colic. Now, these really belong to the museum. Nobody does these procedures anymore. There's been major problems with hepatic failure. Some of these patients require liver transplantation. So these malabsorptive procedures, nobody does them anymore. Instead, we do what we call hypoabsorptive procedures. So the ones that are a little bit common, that are done more commonly, are combination procedures, such as a Roux-en-Y gastric bypass, there's a mini gastric bypass. So basically these combines the hypoabsorptive pathway as well as restriction. So those are the ones that are often done commonly. But sleeve, certainly by now, many high volume centers certainly does sleeve more than any other procedure. So I just want to start first of all, maybe to chat a little bit about the Roux-en-Y gastric bypass. Now, the Roux-en-Y gastric bypass was described in 1994 by Dr. Alan Vedgrove. At the time, it was considered, the gold standard, bariatric procedure, the Rolls Royce, against which all other procedures are measured. Basically, it combines restriction. So in other words, the patient eats less. As you can see there, you create a very small, narrow pouch, the size of 30 milliliters, and then you lengthen the bowel, so the alimentary limb is lengthened. Certainly in our unit, we make it about 1.5 meters. So again, it's hypoabsorptive, because again, it takes a long time for food to reach the bilipancreatic limb, the one that comes from the pancreas side with pancreatic juice. So in other words, absorption is delayed quite significantly. So it's really a combination of both restriction as well as hypoabsorption. And he said he considered the procedure of choice. And this is what we do in our unit. We've now done more than 300 of these patients, and 95% of the procedures that we do in our unit really are Roux and gastric bypass, which is a combination of restriction and hypoabsorption. This is how this procedure is done. As you can see, basically we create a pouch. We try to save the vagus nerve, and then we use a staple to staple the pouch. This is staple the pouch, and then we use another staple to do a vertical stapling of the pouch, just to make it as small as possible. We usually use a bougie, a size 36 French bougie, just to size the pouch. I think it's very, very important really to make a fairly small pouch. And once we have done that, we then measure the alimentary limb, the bilipancreatic limb. We make it about 80 centimeters. We anastomosis that to the gastric pouch using an endoGIA stapler, and the enterotomy is then closed with a suture. We usually use a locking suture, a V-lock suture. We do a leak test just to make sure that the anastomosis is sound, that there are no leaks, because sometimes you may have the tip of the stapler, which certainly may perforate inadvertently, and you may not see that. So a leak test is absolutely crucial for this patient. And how safe is this procedure? The mortality is less than 0.1%. It is the same safety profile as a laparoscopic cholecystectomy, a laparoscopic appendectomy. These patients come in the morning, you operate them, and then they go home. Usually in private, they go home the next day, or they go home after 2 days. In our unit, we keep them about 2 days, then they're sent home. So again, in terms of the mortality, is similar to a cholecystectomy or appendectomy. The morbidity is about 4%, which is similar again to a laparoscopic cholecystectomy. So it's a fairly safe procedure even for these large and very heavy individuals. It's a fairly safe procedure. Sleeve gastrectomy, this was described in 1990s. It is often called or referred to as Magenstrasse and Mill procedure. Indeed, it is the most performed bariatric procedure worldwide. If you look at some of the high volume centers in the US, 70% of patients that are offered bariatric surgery are offered a sleeve gastrectomy. The attraction with sleeve gastrectomy is the fact that in terms of nutritional deficiencies, these patients tend to have least nutritional deficiencies because they have duodenum and pylorus intact. So iron absorption is maintained for these patients compared to the others, compared to a Roux gastric bypass, to a SAD, a single anastomosis gastric bypass. So sleeve certainly has a better complication profile, particularly nutritional complication profile. But having said that, I think it's important to warn the patient, those that want to have sleeve, that 15 to 20% of these patients will regain weight. Now, many people argue that almost majority of these bariatric procedures, patients do regain weight, but certainly sleeve, they regain weight, but also they develop reflux. Even those that don't have reflux, ab initio, they develop reflux, after being offered a sleeve gastrectomy. But having said that, it's still a very good operation in terms of resolution of comorbidities. It is an excellent procedure. In terms of excess body weight loss, it's an excellent procedure. So once again, it's a procedure that is performed quite widely. As I've indicated, in terms of complication profile, it seems to have less complication profile compared to other procedures. So this is how it's done. I see the video keeps on. But basically, we take down the greater curvature. We take the omentum on the greater curvature. It's important to mobilize the stomach, completely. We take down the short gastrics completely, so that the stomach can then be laid down, like a tablecloth. And then we start, about 3-4 centimeters from the pylorus. Because the stomach is thick at the distal end, the choice of the staple height is very important, that we use and choose the staple height, commensurate of the thickness of the stomach in that region. And then as we move upwards, again, we adjust the staple heights. The choice of the staple, very, very important. We use a 36 bougie. And it's very important, again, that this is not twisted. One of the technical challenges of a sleeve is that sometimes it gets twisted. And this is one of the reasons why some of these patients leak afterwards, because the sleeve has been twisted. Now, because the staple line is very long, and you staple all the way from just 4 centimeters proximal to the pylorus all the way to the gastroesophageal junction, is prone to develop a bleed, staple line bleed, because of the very long staple line. So it's one of the things that one needs to watch out, and certainly one can utilize, the clips. You can oversaw the staple line to make sure that the bleeding is minimized significantly. The extraction of the specimen, we usually use one of the pores dilated to remove part of the stomach, because it's pliable. Part of the stomach can certainly be removed, through one of the pores. It is not a reversible procedure, because you've removed that stomach, you send it for histology. But if they have problems, you can always reverse it to something else. For example, we can reverse it to a Roux gastric bypass. Sometimes the patient come in, they have a significant reflux, they significant heartburn, because it's a high pressure procedure, high pressure zone. So we usually convert it to a low pressure, either a Roux gastric bypass. We can do a SAD on it. On these patients, we can do a mini gastric bypass. So there's a whole range of options certainly that can be offered to this patient. Certainly, if they regain weight, one of the things that we can do, either to re-sleeve them, again, to resize the sleeve to make it smaller once again, or we can then combine or convert it to other procedure, as I've already mentioned. Now, there's several hormones that occurs after bariatric surgery. So it's not only restriction, but quite a very impressive array of hormone changes that occur after patients have had, a bariatric surgery. And one of those is the GLP-1. GLP, the glucagon-like peptide secretion certainly is increased in these patients. And there's also a hormone called PYY, certainly is also increased after bariatric surgery. And one of the reasons why, the obesity-related comorbidities, resolve early on is because of these hormonal changes. There's early improvement in hepatic insulin resistance, and this is some of the things that have been attributed to mechanism of weight loss in these patients and resolution of type 2 diabetes after gastric bypass surgery. Now, this is just a summary of some of the hormonal changes that occur after surgery. This is Ruwa gastric bypass. This is sleeve gastrectomy. This is diet-induced weight loss. If you look again, ghrelin is the only hormone. Ghrelin is a hunger hormone. It's found in the fundus of the stomach. And after Ruwa gastric bypass, these patients, ghrelin, if you measure ghrelin, which is hunger hormone, it's very low. And that is why this patient, despite, apart from the fact that they eat very little, they don't feel hungry at all because of these hormonal changes. Ghrelin is down, so they don't feel hungry at all. And these are the hormones, that increases insulin, sensitivity, GLP-1, insulin resistance, GLP-1, CCK, insulin, all of them, certainly, they're all increased in these patients after bariatric surgery. Now, this was a market diligent LCC report that was published some years ago, just to track, some of these procedures over time, starting 2003 to 2017, see, the frequency with which these procedures are performed. Now, if you look here on this graph here, you have purple, which is sleeve gastrectomy. Interestingly, over time, you can see here that sleeve has been increasing significantly over time. Now, adjustable gastric band increased up to 2017. I must say that this is not done anymore. This is a very old report. Nobody does adjustable gastric bypass. But Ruwa gastric bypass also has been a steady increase. But now things have certainly changed somewhat. By far, the commonest performed procedure is sleeve. And this is just another publication by Shaw in 2017, looking at bypass, looking at VBG, looking at band, looking at sleeve. Interestingly, right around 2000, 80% of the procedures that were performed was gastric bypass. But look at around 2008, that's when they started, sleeve started, 2010, 2011, and then as you can see here, sleeve really has been on an upward trajectory ever since. Now, the other procedure is the mini gastric bypass. Now, the mini gastric bypass, basically the difference with this is that you basically make a very long, about 12 centimeter gastric pouch. And then you make one single anastomosis, so basically bypass about almost 2 meters of small bowel. And you make one anastomosis. Again, if you look at the resolution of comorbidities, this is also good. In terms of excess weight loss, this gives you excellent results. The challenge, however, has been bile reflux. There are those who argue about mini gastric bypass, because of bile reflux. Now, bile reflux certainly can be quite a troublesome complication. It's certainly, if reflux is in the stomach, this patient may have problems, but the great concern is when reflux occurs in the esophagus. With the esophageal mucosal changes, certainly there's been cancer reports of reflux, bile reflux in the esophagus. So those are some of the challenges with this patient. But having said that, I think it's still a procedure that should be considered. There are units, certainly in Israel, where this is done quite frequently. In our unit, it's about 5% of the procedures that we do in our unit, mini gastric bypass. We had a patient who had a BMI of nearly 90. We did a mini gastric bypass on this patient, and certainly lost a significant amount of weight. So it is one of those that needs to be considered as a treatment strategy for these patients. Now, having mentioned all these procedures, then how do they compare, these procedures? How do they compare? This was a meta-analysis by these authors, Lee and his colleagues. Basically, they look at several studies published until January 2019, and they're looking at the remission rate of type 2 diabetes, and they found that laparoscopic sleeve gastrectomy was superior. Ruwa gastric bypass was superior to sleeve gastrectomy in the remission of type 2 diabetes. So they concluded in terms of the long-term effects of bariatric surgery, the effect of Roux gastric bypass was better than that of sleeve gastrectomy. What about complications of these procedures? Again, there's no procedure without complications. That the one that is often mentioned certainly is internal hernias. It's not a very common complication, but certainly can occur, and one must be aware of these patients. And there's increasingly more of these procedures that are being performed. So colleagues that do surgery must be aware of these patients. They may arrive vomiting. And on imaging, imaging may not certainly be very diagnostic, but there are certain features that suggest that these patients may have internal hernias. But once again, anyone who has had a Roux gastric bypass arrives at your clinic with signs of vomiting, acute abdomen, that patient should have a scope, should have a laparoscope inserted. And one of the problems that we have seen is that the delay that occurs, because they are often very obese, these patients. Some of them have not lost significant weight. They may be stoic, and their clinical signs may be very deceiving. And it's important, therefore, that they be offered, diagnostic laparoscopy upfront. Imaging, cross-sectional imaging certainly may be very misleading if in some of these patients. The immediate one after surgery is essentially thromboembolism. Thromboembolism, this is what, and usually these patients, we usually have a pharmacomechanical prophylaxis. We put them on pneumatic cuff pumps. We usually start them on Clexane. Usually when they come from theater, we don't give it beforehand. And very importantly, when we discharge them from the hospital, they usually get low molecular heparin for at least 2 weeks. And there are studies that have shown that up to 40% of these patients may develop thromboembolism at home. So it's important that they get low molecular heparin, but very importantly to mobilize. And this is one of the things that is emphasized upfront. Before surgery, that they should mobilize. And these are some of the complications that can occur. The patient can have, obstruction. They can have, remnant pouch distension. They can develop gastrogastric fistulas. So there's a long range of complications. But once again, if you actually look at if you put these in context, it's about 4% again, which is a similar complication profile to the routine operations that we do. For example, a laparoscopic cholecystectomy. The complication comorbidities or morbidities post-lap choline is around 4%, but then the mortality is about 0.1% again. But it's important again to anticipate these complications and be able to deal with them. Now, just the procedure and target weight loss, and this is taken from the guidelines of the American Society of Metabolic and Bariatric Surgery. If you look at sleeve gastrectomy, we are target weight loss around 25 to 30%. The band, adjustable band, nobody does this anymore, but the target weight loss between 20 and 25%. So in other words, if somebody has had an adjustable gastric band, we are looking at target weight loss of between 20 and 25%. Sleeve gastrectomy, if you choose to do sleeve gastrectomy, you are anticipating to lose between, once again, 25 to 30%. But let's look at Roux gastric bypass. Now it's 30 to 35%. Now, if you know bilipancreatic diversion with duodenal switch, BPD, you have quite a significant, especially the super obese individual, the class 4 obesity, you're expecting to lose around 35 to 45% weight loss, these patients. But the problem then here is become nutritional problem. And some of these patients can end up with mortalities. And that is the reason why BPD as a procedure, is done less than 3% in many high volume units around the world. Even though it is extremely good in addressing comorbidities, you pay a very heavy price of malnutrition. They have to come in for IV iron supplements and so forth. And some of them actually have ended up as mortalities. So one has got to think out, loud about, the choice of BPD. BPD can certainly be a very troublesome procedure. Now let's look at single anastomosis, duodenal ileal. This is a SADI. Interestingly, it was really meant to address the very serious complication profile of BPD. So SADI, it still gives you excellent target weight loss of between 35 and 45%, but the complication profile of SADI certainly is significantly less compared to BPD. And this is one anastomosis gastric bypass, target weight loss between 35 and 40%, and there are others, that have been mentioned there. All right, as we say, almost nothing worth accomplishing can be done alone. And this is the team. Here is one of the regional workshops that we do. As one of the patients, as you can see, again, this patient, you can see the legs there, the cuff pumps don't fit. We had to use bandages to hold them together, which is very, very important. Again, here, these are the patients that we have operated here, the top corner there. Now, this is day one. You can see already drinking water there, day one post-op, and then day two, usually these patients go home. This is the team. Again, multidisciplinary team. Is a formidable team, of individuals there that, again, here, the anesthetist again, the dietitians, the physiotherapist, all of those very, very important in making sure that the outcomes of these patients are what is expected. This is a team from Sweden that visit our unit here. This is some of my fellows here who also do bariatric surgery. I thank you for your attention. I think I'm happy to take any discussions, any questions at this point. Thank you very much.
Thank you very much, Prof. Koto. Quite an illuminating discussion, and also always a pleasure to listen to you when you give a talk. And we can even see by the numbers that have joined us, the signal that you always have something that many people want to listen to. And your track record also speaks for itself, that you've got quite a formidable team that works with you at the university and also the hospital, Dr. Josh Mukari Academic Hospital. There's a first comment here that someone was saying, I think you mentioned that in your presentation. They are saying that BMI is no longer used as a tool for managing weight loss, and because it is too simple. Maybe the person, I think they said in June 1990, June this year, June 4th, this year, it was mentioned about that. So you did mention that. I'm not sure if you want to make another comment just to re-emphasize that. Can you hear me? You're muted, Prof. You're muted, still muted.
Okay, yeah, no, I was not able to unmute myself. I think.
Okay.
Yeah, no, thank you very much. Yeah, no, I think the colleague who I think is absolutely correct that BMI, I think for the reasons I've mentioned in my talk, it's got serious limitations, and it certainly may miss out a lot of patients. But it is a proxy to what we're dealing with. It's very practical and it's very easy to utilize. So I think we still utilize it. I think as surgeons we still utilize it, to making the decision. And now, if you look at the recently published guidelines of the International Federation of BT Surgery, IFSO guidelines, they still talk about BMI in deciding which patient should be offered surgery. But I think they also mentioned that because it's got serious limitations, patients should be, judged on individual merit. That is why we have a multidisciplinary team, that looks at these patients. And for example, if somebody has got a BMI of 23, has got, diabetes is very difficult to control, it would not be unreasonable to offer that patient, metabolic surgery, even though the guideline says, 30 to 34 and so forth. So it's not cast in stone. But one of the things that is a fairly good predictor of visceral fat is I think, waist circumference that I mentioned. But those, yes, again, are challenging. I think it's a very comprehensive assessment of these patients that involves, not only the BMI, but looks at a whole host of other things. But it is certainly a proxy. It is a very easy tool to utilize, but it's got serious shortcomings. And I agree with the comment that was made. Thank you.
Thank you very much. I just want to go to the Roux-en-Y surgery, maybe my uninformed knowledge about this. I thought this has been quite a surgical procedure that has been taught for many years. It was not initially meant for weight loss, if I may understand. It was just a procedure that was used for addressing some other complications in abdominal injuries, if I'm correct, or other pathologies.
Yeah. I think Ray, you hit a nail on the head. I think by accident, Roux-en-Y is really a reconstruction of the gastrointestinal tract, and we use Roux-en-Y for a variety of reasons. We can do Roux-en-Y to drain pancreatic pseudocyst. We do a Roux-en-Y to drain the biliary tree. We do a Roux-en-Y to drain the gallbladder. It's a very versatile limb, so which we create in the form of a Y. After gastrectomy, gastric resections, we may do a Roux-en-Y to reconstruct the stomach. So it's very versatile. And people began to see, many years ago, after gastric resection, when they do a Roux-en-Y reconstruction, people began to lose weight. And this is where it started. That, it looks like, if you do a Roux-en-Y, you make the stomach smaller, some of these patients lose weight. So that's how it started, So then it became now a very focused procedure to losing weight, where we deliberately make the pouch small, we lengthen the alimentary limb, we delay the absorption, now as a strategy to losing weight. But I think you are absolutely correct that it is a procedure that has been utilized for many, many years for other reasons. And it by chance, it became a procedure, that was now utilized for weight loss. Yeah.
Okay, thank you very much. Now, going back to the BMI, what are the guidelines that you would give to maybe someone who comes to a practice, a GP practice, and they're looking at the condition of the patient, and they, in their mind, it's an obese patient, so they should not be hesitant to refer a patient based on the BMI.
Yeah, absolutely. I think the IFSO guidelines, are very clear. And what is very frightening is the fact that patients that qualify for metabolic surgery, only 1% to 2% of those worldwide get the procedure. 98, 99% of them don't get the procedure. So if a colleague who's in practice, sees a patient, for example, an obese patient, so the guidelines are, if a BMI is more than 30 to 34, and they've got obesity-related comorbidities, and these are, for example, hypertension. It's got hypertension, that's obesity-related comorbidities. It's got dyslipidemia, that's obesity-related comorbidities. The patient has got osteoarthritis, obstructive sleep apnea. They sleep, when they sleep at night, they obstruct. Those patients certainly should be, considered for bariatric surgery. Anybody who's above 35 BMI should be evaluated for metabolic surgery. Now, there are others, for example, if a patient has got, hernia, for example, is obese, has got hernia, instead of repairing the hernia, because the likelihood of success when their BMI is very high is very low. So in other words, they tend to come with recurrences, they have reflux, heartburn. If you do an anti-reflux procedure for those patients, the chances of success is minimal. So those patients tend to do very poorly. So the guidelines are very clear: address the underlying problem, and then we can then deal with, which is obesity. Then we can deal with that approach. So I think the short answer to your question, Ray, is that Anybody with a BMI of above 35, I think should be assessed. They should be referred. And then again, we should screen them, once they assess them in practice, check somebody's BMI, check, premature deaths, these patients, now you can give them their lives back. You can, in a way, cure their diabetes, cure their, their hypertension. We have one of the administrators in our department who has said this, but was diabetic. Now it doesn't take diabetic medication anymore. Now for the last 3-4 years has been cured of diabetes. So it's very powerful intervention, I think, for these patients in terms of resolution of comorbidities here.
Thank you very much. There's a hand by Professor Ali. He's a gastroenterologist. You want to raise your hand? I mean, you've raised your hand. Just unmute yourself or come on help of Ali to unmute, and then you can ask your question.
Good evening, Ray and Zach. Good evening to all the listeners. Thank you for excellent presentation, Zach. Just to comment in a question, you've mentioned all the problems associated with surgery, obviously the reflux, the bleeding, and things like that. People should be aware of that. Just as a comment, I saw Faisal in the background there. What is the role of endoscopic bariatric kind of surgery? Is that gone out of fashion now? Are people still placing balloons and funny stuff? And my second question is, in the reflux, it's obviously not acid anymore because there's no much stomach. So how do you control the bile reflux? Thanks, Professor Koto.
Yeah, no, thank you very much, Prof. Ali. Excellent question. Endoscopy, the role of endoscopy, I think the balloon certainly still has a role. I think it must be understood that, a balloon in terms of, long-term effect certainly is not something that gives patients long-term results. But I think it's, there's a subset of patients who, for example, there's an occasion they want to lose weight. Certainly a balloon can be placed for these patients. But we know that as soon as you remove the balloon, these patients regain weight. But there are also other current endoscopic procedures now where you stomach partitioning, endoscopically. Certainly, that seems to work. There's some studies that seem to suggest that that works in terms of weight loss. But there's been some studies following these patients up over a period of 12 months, more than that. They seem to have, high failure rate, with this endoscopic stuff. But I think it's work in progress. Endoscopic management of these patients, work in progress. And some of these patients who have had Ruhr gastric bypass certainly can be offered endoscopic control. For example, the gastroesophageal anastomosis, that anastomosis, if it's big enough, it's just big, the patients tend to have, dumping, they tend to have all sorts of problems. And one of the things that can be done to address that is endoscopic narrowing of that gastroesophageal. So in terms of the role of endoscopy, certainly is still there. Balloons are still there, but I think one needs to understand that they have limited efficacy. Endoscopic stomach partitioning also, I think over long-term results, I think there was a study 12 months follow-up study, which showed that these patients seem to have problems afterwards in terms of failure rate. The sutures tends to come off, but I think over time, these techniques certainly will improve. I missed the second question, Prof. Ali.
The treatment, the management of the reflux, because it's obviously not acid, because there's no more stomach.
Yeah, that's right. Yeah, interestingly, depending on the procedure, for example, if you do a single anastomosis gastric bypass, so basically you are taking a limb of bile to this pouch, anastomosis to the pouch, and then bile, as it comes from the duodenal end to the ampulla end, and then past the pouch, some of this bile gets into the stomach. So it is bile reflux. It is very difficult, Prof. Ali, to treat that. People have used, coating agents and all sorts of things. Well, obviously, PPIs will not work there because it's acid, as you correctly point out.
Yeah, we used to use arsenic in the olden days. Yeah, but it's not available anymore commercially. So
you're absolutely right, Profile. I think those patients, once the reflux becomes incapacitating, you might have to reverse that, So the reversal then will be to offer them a Ruhr gastric bypass. Now, the Ruhr gastric bypass, reflux is very rare there because
Little,
you make,
yeah.
your alimentary limb is very long. So the possibility of reflux certainly is less. So I think if you come incapacitating, it may call for revision of that particular patient.
Thank you, Zach.
Thanks very much.
Thanks, Profile. Thanks for your comment. You mentioned someone in the audience, Redwan. So Dr. Faisal is here, is a pediatric surgeon, or you want them to comment?
Oh, no. I saw Faisal in the back of Prof. Koto's team. Faisal Goa.
I see.
He's a physician gastroenterologist there.
Oh,
all
okay.
right. Yeah. No, we've got quite a number of other colleagues who are from the multidisciplinary team. I'm not sure if there are any of the dietitians who want to comment on this. And how these patients, when you discharge them, you say they go home and then you put also them on the antiprophylactic anticoagulation. And then is there a long-term follow-up with the dietitian?
Well, absolutely. I think this is, again, the American Medical Association, again, declared this a chronic disease. So I think it must be understood in that context that it is a chronic disease, and this patient needs, long-term follow-up. And that is why it's important that, the dietitian followed up. And one of the problems that they have long-term is malnutrition. They need iron, they need thiamine, they need calcium, they need magnesium, and these need to be checked, on a regular basis. Some of them develop night blindness. They don't get vitamin A, they get night blindness, these patients. Some of them get neurological problems because they don't have thiamine. So I think your question is very pertinent. They must be followed up by dietitians. And I'll be glad to have colleagues who are dietitians on the call, if maybe they could comment on that. But certainly in our environment, they get followed up by dietitians, they come. But some of them disappear. The patient, patient being patient, even after a thorough explanation, sometimes they disappear and then only rock up, with problems, of neurological problems, weakness because they have thiamine deficiency, night blindness because they have not been taking their supplements. Yeah.
Okay, thanks a lot. There's a question from Lindy where how do these patients join the program at SMU, Dr. Josh McCall? The second question is also, you and I had this discussion previously about also if there are any surgeons here who want to be part of the program, how do they get in touch with you to be trained as you? This is one of your traits, that training the new generation of surgeons.
Yeah, I thought the first question about the program at Josh Mokar is one of those. I think we're very grateful to the Gauteng Department of Health. I think they've taken a conscious decision to make this treatment strategy available to the indigent patients, of the province. It started in the Western Cape. They have it there at Tigerberg. Certainly, we offering it. I know VETS is in the process of putting that together at Helen Joseph. I know Steve Biko. They also have been accredited, to it. So there is a very focused strategy to make it available in all tertiary hospitals. Because as I said, it's only 1% of patients that require this procedure that get it, 1 to 2%. So 98% are these that develop premature deaths, other problems, cancers related to obesity and other comorbidities. So the way you have a program, they book an appointment, they get seen at the MDT. We have the Department of Clinical Psychology is heavily involved in this. The Department of Dietetics in our institution is heavily involved in this. And then we have physiotherapists, so they get booked and then they get seen, until all these reports have been made, and then they're discussed at the MDT meeting where we make a decision about, what procedures to offer them. Now, regarding your second question around, the individuals that want to get involved, fortunately, the South African Society of Endoscopic Surgeons, I'm an executive member of that society, have now put together very robust and very clear and articulate comprehensive guidelines, in terms of the training pathway, accreditation pathway. We've had Aquilo, which is an international body that accredits bariatric surgery internationally, that came accredited. Now that function has now been taken by the South African Society of Endoscopic Surgeons. We now have we accredit not only surgeons, but also hospitals that want to start this program of bariatric surgery, as well as proctoring. For example, proctoring, there are now arrangements, from the South African Society of Endoscopic Surgeons. It's a subcommittee, which is a South African Metabolic Society. They also offer that accreditation process.
Okay. So any surgeon who wants to follow that route, they are free to make inquiries from that society.
Absolutely. Yeah, absolutely.
Yeah. And Dr. Ubitumele wants to know, what are the age restrictions of bariatric surgery? We are seeing increasing obesity in childhood and teenagers.
Yeah, I think that's an excellent question. If you look at the IFSO guidelines, once again, children as well, can we offer, we have, bariatric surgery in children? Absolutely. Children, again, there are certain guidelines clearly, patients that are 120% of the 95th percentile, body weight, children certainly can be offered, bariatric surgery. But once again, we have to be very careful about the choice of procedure in children. For example, they are still growing, so you obviously will not go and offer them a lower gastric bypass. So the ones that usually will end up with a procedure that offers you least nutritional, problems, such as a sleeve gastrectomy. So those are the ones that will be offered sleeve gastrectomy. And then we have the elderly patients. Is that a contraindication? 65, 70? The answer is no. Each individual should be assessed on their individual merit, so in other words, a 65-year-old who's obese certainly can be offered. So I think the short answer to Dr. Kinoshi's question is that certain children can be offered this bariatric surgery. Of course, they need a very careful and meticulous assessment by the multidisciplinary team. Elderly patients, again, each patient must be offered, must be assessed on their individual merit. Also, there is no absolute contraindication to offer metabolic surgery for those patients.
Okay. Thank you very much. I don't see further questions, and we don't have to keep you long because you miss your dinner. I think it's way past 8 that side now in Mombasa, Kenya. And we just want to thank you very much for, whilst traveling, for availing yourself and giving us this time to talk to us and do this wonderful presentation. On behalf of Clinics Health, I just want to thank you very much, Prof. Koto, for this wonderful presentation and for your time also. And we know that we can always call on you when we need more information, advanced information, and pertinent research that's advances that you are making. Making an impact, and we also know that you are also making an impact there in Africa as you are part of that team that is in Mombasa. And also to thank all the colleagues who have joined us this evening. Thank you very much for joining us, and also colleagues who are participating and other clinicians who are in other disciplines. Thank you very much, Prof. Adi, for joining us also, and others that we have not mentioned by name. That we thank you very much for being part of this webinars every week. And we look forward to hosting you again next week. We'll look at some innovation in terms of medical practice and clinical care. We'll bring a young person who will be talking to us next Thursday. And we just want to also thank the Clinics Health Group team, marketing, Kamo in the background, for working together with me that we should bring this webinars on a weekly basis. And we just want to say thank you, colleagues, and have a good evening. Thank you very much. Good night.
Thank you, Ray and Zach. Good night.
Thanks for
that.
that.
Thank you very much, everybody. Thank you. Bye-bye.
Thanks, Zach. Bye.
Good night. Bye-bye.